What is locked-in syndrome? Locked-in syndrome is a disconnection syndrome that mimics the signs of impaired consciousness. While consciousness and sensory input are present, brain damage prohibits voluntary movement. In other words, the body is de-efferented. So what causes locked-in syndrome? It's caused by damage to the ventral pons. As you can see, there are lots of ways that the pons can be damaged. And as indicated by the chart, the three main causes are either vascular in nature or a result of traumatic brain injury. Most cases of locked-in syndrome are caused by a basilar artery stroke resulting in bilateral ventral pontine lesions. A basilar artery stroke can result from a hemorrhage or occlusion that causes an ischemic event resulting in pontine infarction or local tissue death. Here we see the basilar artery providing blood to the ventral pontine area. Typically, locked-in syndrome affects cranial nerve 5 and below. Muscles producing vertical eye movements are spared, so clients with locked-in syndrome can blink. There are also non-vascular issues that contribute to locked-in syndrome. The second most frequent is traumatic brain injury. Locked-in syndrome is extremely rare. The incidence is unknown, and the first study regarding prevalence of locked-in syndrome was conducted in Dutch nursing homes in 2013. The prevalence of the study for classic locked-in syndrome was 0.7 out of 10,000. Locked-in syndrome is related to neurological diseases such as multiple sclerosis and Guillain-Barré syndrome. There isn't a lot of information regarding locked-in syndrome. The France-based Association du Locked-in Syndrome, ALIS, collects information about its members, which in turn is utilized by scientific literature for demographic purposes. The demographics show that older adults are more likely to suffer from locked-in syndrome. Biological sex characteristics do not play a role. 44% live at home, 21% in the hospital, and 17% live in a rehabilitation center. On the left, we have a timeline of sudden onset vascular locked-in syndrome. Typically, there's abrupt damage to the pons with upper motor neuron symptoms. There's a coma lasting from hours to weeks, and then the client will wake up with symptoms of locked-in syndrome. These symptoms are a preserved cognitive ability. A majority of clients can hold attention, are aware of time, and can read, and a minority report memory problems. Nearly 100% are sensitive to touch. Quadriplegia is a symptom which can also result in dysphagia. Clients tend to have anarthria due to facioglossopharyngeal paralysis, and they can have aphonia, though 78% are capable of emitting sounds. Communication is limited to voluntary eye movements, and some have vision problems due to traumatic brain injury. The majority of clients report that they're more emotionally sensitive. This could be related to emotional lability and is often misdiagnosed as psychological disorders such as depression. There are different types of locked-in syndrome with various levels of impairment. Classic locked-in syndrome is a total immobility except for vertical eye movements and blinking. Incomplete locked-in syndrome is remnants of voluntary movements, and total locked-in syndrome is no movement at all. Locked-in syndrome often leads to a severely disabled state and has a death rate of 60%, often due to initial pulmonary complications. Acute care is critical to outcomes. The literature suggests that aggressive and early rehabilitation is important, and members of the medical community are advocating for the term brain attack to suggest prompt treatment is important as a heart attack. After medical stabilization, life expectancy increases to several decades. There's no known cure, and recovery is improbable but possible. Favorable predictors include young age and non-vascular etiology. Locked-in syndrome first appeared in literature in Count of Monte Cristo, and there are many accounts of locked-in syndrome that give a humanistic perspective that may be of interest to an occupational therapist. This is Jean-Dominique Bauby, who is an editor for Elle magazine and suffered stroke resulting in locked-in syndrome. He dictated his autobiography, Diving Bell and the Butterfly, by blinking his left eye. The book is a prominent first-hand account of the disease, and he founded ALIS in France, which has done a lot to bring global awareness to LIS and also contributed to scientific research in the form of demographic information. This is Martin Pistorius as a teenager. He's been living with LIS since the age of 12, but was misdiagnosed for over 10 years. Eventually, a relief care worker started up a conversation that was a catalyst for more cognitive testing, and he wrote a book called Ghost Boy about his experiences. Theoretical physicist Stephen Hawking suffers from Lockton syndrome as a result of a progressive motor neuron disease related to amyotrophic lateral sclerosis, or ALS. There are many ethical concerns that must be considered when caring for clients with LIS, considering limited communication. Diagnosis can take years, on average 78 days. Looking for detection of awareness is important. People should be part of their decision-making process to preserve dignity. One study cites the Dignity Conserving Care DCC model as a useful guide. Tony Nicholson gained widespread attention for his legal battle for assisted suicide. However, the wish to die is atypical, as 95% are glad to be alive. There is no set treatment for Lockton syndrome. The literature suggests that immediate, holistic, and multidisciplinary treatment is very important, but 47% of clients do not receive. Only 47% of clients receive rehabilitation. Acute care happens initially and is important to outcome. Critical care can include many life-saving tasks. If Lockton syndrome is ischemic in nature, medical care teams can perform thrombolysis or endovascular treatment to reverse effects. Pharmacological treatment is used in 66% of clients, typically muscle relaxers, blood thinners, and antidepressants. Neurological tests are important to understand what's happening in the brain. Brain imaging can assess damage, while auditory evoked potentials can assess brainstem function when the client is comatose. Augmentative and alternative communication optimizes communication for a better quality of life. Clients with complete Lockton syndrome may need a brain-computer interface that does not rely on visual stimuli. A communication specialist can help choose an appropriate device, such as this classic communication device, an alphabet board, that requires no technology, and the client communicates with eye movement code. A client-guided system that scans eye movements can be coupled with computers through spelling systems. An open-source technology can be used, in this case, to draw with eye movements. This is a good example about how communication devices can and should be tailored to fit individual needs. Rehabilitation is important. This is a photo of Pistorius with his wife after he received rehab. Physical therapy can help strengthen, mobilize, and reduce spasticity. Speech therapy strengthens the diaphragm and helps with communication. Swallowing therapy helps swallowing reflexes and related movements while introducing food and drink. Respiratory therapy exercises breathing and chest mobilization. And occupational therapy increases upper motor skills, and helps with autonomy of activities of daily living, or ADLs. The literature suggests that Lockton syndrome is undertreated, citing that as a syndrome looking for a therapy and a challenge for therapy. It's suggested that treatment of Lockton syndrome has been historically pessimistic and strongly advocates for post-acute, long-term, intensive, holistic, and multidisciplinary treatment programs in the future. Another hopeful aspect is that technology, such as a direct connection between brain and computer, can perhaps move patients from a classic to an incomplete Lockton state in the future. Thank you.